This is Linda Burhan-Stipanoff, or Linda B. I'm with Native American Cancer Research Corporation. I thank you for spending about 90 minutes with us on this. And this is an overview about screenable cancers. Today is on breast. We have other days that will, like tomorrow will be on cervix. Next week will be on lung, colorectal, and prostate. So we're covering the screenable cancers, and then we also will have webinars that are on advanced motivational interviewing, behaviors, and skills. So this is offered by the Alliance of Patient Navigators, Community Health Workers, and Promotores de Salud. The mission of the Alliance is to address disparities, and the purpose is we're trying to make these different positions sustainable. And so this is one of several different projects that the Alliance has ongoing to try to improve the status of patient navigators, community health workers, and promotores de salud. So when we start these, we're going to go through different sections. We're going to go through the anatomy of the organ. It'll cover some facts and fallacies. It will cover some data, some suggested information, if it's available, about how this cancer affects Colorado, especially for underserved populations. It'll also suggest some strategies for what you can do as a community outreach worker or a promotora or a patient navigator to help bring more people who are not being screened in for the appropriate type of screenings. So the anatomy for this one is that we're dealing with breast tissue, and a lot of people think that the breast tissue is just the part that protrudes from our chest, but it's not. It's not just what we support in our bras. It continues all the way up to your collarbone, and it extends to under your arms. Likewise, it goes all the way to the center of your ribs and the bone plate in the middle of your chest. If you look at where most breast cancers are located, about half of them are close to your upper arm. And as that diagram is showing on the screen, it's the upper outer quadrant. We do have breast cancer appear in other parts. So on the screen, it's showing you that there are some that are on the inner quadrant. But note that about 18%, that's almost 1/5 of all breast cancers, are in the nipple. And it's important for that because sometimes people will have unique signs or symptoms and they don't pay attention to something that's a little bit of drainage from the nipple. This is a diagram that's showing the ducts. So on the diagram on the right, this is referring to the milk ducts here, and that's what carries milk if you were pregnant. And the lobules these are the mammary lobes here, mammary lobes. And again, they produce the milk when you're pregnant. And the lymph nodes are up under the arm. And these help to fight infection. These help get rid of excess infection. They help modulate fluids that are in different tissues. And then we have hormones that are secreted throughout the body, and they affect actually your entire body in different ways, and cancer can affect any of these. Now, a lot of times we talk about breast cancer, people think we're talking about one disease, but it's more than 15 different types of distinctive diseases. So there's different types, and they spread and they act differently in the body. For example, some types of breast cancer actually spread at the same time that they're growing, a small tumor is growing, and others will not do anything. They'll grow, and then once they're fairly large, then they start to spread to other parts of the body. So the cancer acts differently from one another, even though they're all breast cancer. To give you an example, this is just showing that the majority, these are not cancer yet. This is when it's cancer, and ductal carcinoma means it shows up in those ducts that were in the diagram a couple slides ago. And this is where the majority is. But you got this other group that's down here, 1.8. And that includes other rarer types of breast cancer. But if I have a patient that I'm working with, and he or she, I note he or she, if they have cancer of this type, their cancer treatment is likely to be totally different than it is if it's any of these other types. If you have a patient who has triple negative, they are treated totally different than other cancer patients are. It's much more aggressive type of a treatment because it acts differently than other cancers also. So some common facts and fallacies, and basically I put in fallacies on most of these. For example, most cancers caused by environmental pollution. We would like to believe that, but in reality, most cancer is caused by our daily living, what type of behaviors we do every day. And a lot of people that you work with are going to say, I don't need to go in for cancer screening because nobody in my family has ever had screening. Well, even though we say family history is a risk factor and increases your risk, for the majority of people, you're going to be the first one in your family who's been diagnosed with breast cancer. And some people think that cancer spreads if you are close to someone else. So they find out that a neighbor has cancer, and when they see that neighbor in town, they cross the street so they're not near them because they're afraid the cancer will spread. And that is not what that's not what happens with breast cancer at all. Other people say cancer spreads when one gets surgery, and there's an issue with this, that the tissues opened up to more oxygen during surgery and that may spread it, and that is really kind of iffy how well that works with different types of cancer. You will have people in your community who still think that cancer is an automatic death sentence, and if it is, then why get screened, because you're going to die anyway. And they'll make very fatalistic comments like that. They make the comments like that because the people that they've known in their local community, like there are many Latino women who don't have access to screening and treatment, and they're frightened. They say, but I'm not going to get screened because I can't be treated anyway. And what you have through the state programs are ways to get people into treatment. It is not an automatic death sentence, but people have only seen the people die. So what we're trying to do with many of the programs that are throughout the state is to help people realize we can change that perception. We don't have to be feeling so fatalistic about cancer or the diagnosis. So the beauty of the cancer screening is it identifies the cancer when it's early stage in development. The earlier the stage of development in general, the more likely the person is to totally recover from the cancer. We are now seeing people who have cancer that have normal lifespan. So they're very, very important to get people into screening. And you'll have many women, especially somebody who's very, very slender and very skinny and has very small breasts. They don't think that they're at risk because their breasts are so small. But the issue is all you need to develop breast cancer is breast tissue. This is why males also get breast cancer. It's just not as frequently as it is for females. And risk decreases with age. The older we are, the less at risk we are. This is absolutely just the opposite. As you grow, age is one of the larger risk factors. Being a woman is the biggest risk factor for developing breast cancer, but age is the second biggest. Now, that doesn't mean that young people get breast cancer. They do. We do have breast cancer patients who are in their 20s. The difference between breast cancer in a young person and breast cancer in an older person is that it tends to be slower growing when you are older. If you have a young woman who's 20 and she is diagnosed with breast cancer and she says, I don't want to go through the treatment, I don't want to lose my hair, her hair will grow back, but she has to get into treatment quickly, because if you are young at the time of diagnosis, cancer tends to be much more aggressive. Aggressive means it grows faster and it spreads faster. So you have to be very, very vigorous in particular with young people. And this next one is just kind of a general comment that's saying, hey, if you smoke, it's okay if you have natural tobacco. Now, natural tobacco is like what we use in my community for ceremonies. You don't inhale sacred tobacco because it's too harsh. It doesn't have any of the additives that commercial tobacco has. But tobacco itself is a harmful agent in your body related to cancer. It's not just the other chemicals that are in commercial tobacco. However, what we've got, come on, are you not working? Breast cancer is not as strongly linked with tobacco. Like for lung cancer, we know that smoking actually causes the majority of lung cancers. It causes about 30% of all cancers. But of the different types of breast cancer, there are only a couple types of breast cancer that we see a direct link with tobacco use and breast cancer. So it's not as big of a risk as it is for other types of cancer. And you'll hear other people who will say, it can't be bad because my grandfather smokes. He smoked since he was 12. He's not dead. And they'll come up with many other comments like this. Well, part of this is that there are genetic strengths that we're all born with. And there are some people who don't experience the damages of tobacco as easily as the rest of us do. And there is an extra protection. The problem is you don't know if you have that protection or not, which is why we're encouraging people to cut down or to not smoke at all, if that's possible for people to do. And this last one is a myth. Also, these are all myths. Young women under 30 do not need to be concerned about breast cancer. They do. The problem is they can't get into screening. So in your state-sponsored programs, it's difficult for you to get into screening. If you have Susan G. Komen for the Cure funding for your program, you can get a young woman in for screening. They have to do it differently because the breast tissue is so dense. A mammogram has a hard time showing where the tumor is because the breast tissue itself, when you look at the x-ray, just looks black and you can't see a tumor, and tumor shows up lighter or white in them. And I'll show you a couple pictures in a minute. The next, and this is just emphasizing the bottom of the screen, is that the younger the woman is at the time she's diagnosed with breast cancer, the more aggressive it is that she has to get into treatment. So overall, who can develop cancer? Anybody. It knows no prejudice. It's found in all racial groups. Both men and women develop cancer because both men and women have breast tissue. But one of the things that's quite important is that your chances of developing cancer are going to increase as you grow older. So cancer develops over time. It's a result of a combination of different mixtures. Most of them are related to your daily behaviors. How much exercise you get. We know that daily physical activity is one of the very, very good ways to reduce your risk for breast cancer. But you could be exposed to environmental contaminations. You may be one of the few people who have a hereditary risk. When I say few, is that the hereditary risk is only about 5 to 10% of all breast cancer is caused by what you inherited from mother and father. Now, it has a little slash on the screen for genetics, and that's because all cancer is genetic, but genetic doesn't mean inherited. Inherited means that you received the trait that increases your risk for breast cancer from either the egg or the sperm when you were created. Because men also have breast tissue, they can get breast cancer. They cannot be screened in most cases through your program, but they can be screened through Susan G. Komen for the Cure. You have to get permission for that. They have to be screened a little differently because they tend to have more muscle mass than do women, and their films are very dark. It's hard to actually see the tumor within a mammogram, so they frequently have to get a different type of a test. Lesbian women are also at risk for breast cancer. Occasionally you will hear people in the community say if they're lesbian that they're not using their breasts in the same way or whatever, and there's all different types of silly thoughts about lesbianism. But lesbian women have breasts, and it's important for them to take part in screening. At your clinic, you want to make certain that they feel welcomed to come in, that your questionnaires don't refer to a husband or male partner. It can just be partner, things to make them feel a little more comfortable so that they take part in screening as well. And there's so many subtle ways that we kind of make it a less comfortable environment for lesbian women. Young women also develop breast cancer, but they go through different types of screening. And the size of the woman's breast doesn't matter. Small-breasted women also get cancer. And the younger the woman is at the time of the cancer, the more aggressive it is. And you have to have different types of screening because women who are young, their tissues are too dark. So I'm just repeating the kind of the flip side of what the myths were. So your risk, the biggest risk for breast cancer is being a woman. The second one is growing older. The third one is that if you have had breast cancer once, you are at high risk for having breast cancer a second time, which is why some women, after they have been diagnosed with cancer, they think, okay, I've already had it, so I don't have to go back to get any more screening. And it actually, they may need to go more frequently than other women who have never had breast cancer. You also are at risk if the people you're working with have had a different type of cancer. So if you have a woman who's had ovarian cancer, she is at greater risk for having breast cancer. Colorectal cancer, there's a great risk. Lung cancer, there's a greater risk. So different types of cancer or even have a greater impact on your risk for breast cancer than other types of cancer. And that's why you want to go in regularly and follow the guidelines that your provider tells you. Now, the hereditary risk, meaning inherited from mom and dad, BRCA1, the BR on this stands for breast, the CA stands for cancer. The 1 means it was the very first marker that was identified for breast cancer. BRCA2 means it was the second marker. There's a third one called HER2-neu. There's triple negative. These are 4 of the most common breast cancer hereditary risk. About 5 to 10% of all breast cancer fits into one of these 4 types. But these are very, very specific. You occasionally are going to have people in your community who say, cancer is all over my family. So doesn't that mean I have a hereditary risk? And you have to learn a little bit more. And if you want to talk about it sometime, you can contact me. But you ask them questions about what types of cancer. So they say, oh, my auntie had multiple myeloma. My grandfather had skin cancer. We had a nephew who had brain cancer. Well, none of those cancers are related to these 4 genetic risks. If they're not related to it, there's no reason to have the woman take part in these tests. These tests are thousands of dollars. And a lot of the women and men who you work with in the community don't have extra money to be spending $1,000 for a genetic test they don't need. When in doubt, and as a navigator or community health worker or Promotores de Salud, you do not have to know these things, but you do know to have them first referred to a genetic counselor so that it can look at family history and you have somebody who's qualified who can say, you don't need to go for this test. It's not you making that recommendation to them. Then family history, if you have breast, colon, lung, ovarian, prostate, those cancers in particular are very, very tied in to one another for different genetic risks. So family history can have a lot to do with how somebody's risk or likelihood of developing cancer is. Sedentary lifestyle means they're not getting enough physical activity. Now, in some of your communities, you've got people who are doing ranch work, or they're outside, they're doing a different vigorous type of work. This doesn't mean an exercise class when we talk about sedentary lifestyle. It's referring to, do your muscles get worked every day? Are you breathing heavily with the type of the work? And it could be regular work that you're doing every day. Maybe you're a nanny. You're chasing kids around the house all day long. That is not sedentary lifestyle. So these are not exercise classes. This is body movement, body stretching. So breast cancer risk, the other thing that's important is that if you're over your recommended body weight, and it's probably more like 20 to 25 pounds rather than 15 to 20, typically it's also collected to not just overeating, but eating higher fat foods or high calorie diets, candies and cookies, especially this time of the year near Halloween. For women who drink more than 7 alcoholic drinks in a week tends to increase the risk. For men, it's more than 14 drinks in a week. If a woman has never had children through her own birth canal, so it's not talking about somebody who adopts. We do a lot of that in our community, but that is not what this risk is. It has to do with how your hormones change when you are pregnant with a child, on why this is a protection or no protection. When you have a child, you want to breastfeed for more than 1 year. And that basically is because it reduces the estrogen that's in your body, and a lot of breast cancers respond to estrogen, and that gives your body a break. If your body gets a break from the estrogen, it gives your body a chance to fight back against the breast cancer itself. So it's important for that particular thing. So to reduce the risk, then obviously if sedentary was a risk, if you have daily physical activity, it's very helpful, and a low-fat diet, limited or no alcohol, taking part in early detection screening. And keep in mind with this one that most women who get breast cancer have none of the risk factors other than age and gender. And they're the first in their family to be diagnosed. So this is why we still have to do screening. They are the first ones to be diagnosed to their family. Now, there are the U.S. Preventive Task Force. That's what that acronym stands for, United States Preventive Task Force. They have screening guidelines. This chart is a summary for a lot of different types of cancer, but the only part that we care about right now is breast cancer. If you are receiving state funding, and if you were working with the Indian Health Service, because you have people who are in the Southwest with Ute, Mountain Ute, Southern Ute, as well as we have screening programs up here close to Denver. Excuse me. You have to follow these guidelines or you cannot get reimbursed. And it could be that your patients get charged for screening if they are outside of these guidelines. Now, you're going to have a lot of women and men who are not in those guidelines. And again, that's where Susan G. Komen for the Cure, there are a couple projects in the state that have Avon funding. That's where those people can be screened from those funding sources. But according to the U.S. Preventive Task Force, if you are normal risk between the ages of 50 and 74, that's who they want screened. You have a 75-year-old woman comes in and she says, I want to be screened, and you're being supported by the state program. You have to get permission before she can be screened. Because again, you may not be able to get reimbursed. The reason this is set up this way is because of women who are diagnosed after age 75, the cancer tends to grow so much slower, and that the mammography is probably not as effective in the older. The younger women, this is an issue for my population because half of our women are diagnosed before age 50. Now you can get a baseline screening at 45. And again, check to make certain your women are going to be covered by that. Excuse me. And overall, it's every 3 months. It used to be every year that we tried to do screening. Now, if a woman has had an abnormal mammogram in the past, and maybe she's had different types of cysts and she's had biopsies, she is not normal. This is normal risk here. And she is likely to be recommended for screening every year. Sorry. So the U.S. Preventive Task Force breast cancer screening guidelines, the standard risk 50 to 74 every 36 months. If you're high risk, and this is how high risk is defined. If you have a sister who was diagnosed with breast cancer, you have a mother, or you have a daughter who was diagnosed with breast cancer. So in other words, it's a parent, a sibling, or a child. You are high risk, and you are typically recommended to go in for screening at least once a year. If you have a genetic risk, meaning that BRCA1, BRCA2, HER2 new, or triple negative. If you have unusual symptoms, for example, some young women have some discharge from their breast that can be normal. It can be related to their period, but the doctor may decide it's not normal, and they can put them into the high-risk group, and then they take part in screening. You as a patient navigator or community health worker or Promotores de Salud, you don't make that distinction. You help make the patient, help the patient get in to see the doctor to make certain the doctor thinks that this person is high risk. And then you try to support them. When you support them, they may be recommended for a mammogram. Now, a mammogram is not a perfect test. It's the best that we've got in general that's fairly cost effective. There's research going on that they're looking for alternative ways to do the mammogram that are much more technical, and I'll show you a couple screens that what different mammograms look like. But it's also they're looking at totally different ways to diagnose any abnormality of the breast earlier, and maybe with less discomfort. Some women find a mammogram where it squeezes the breast down to be very uncomfortable. If it's a young woman in particular, or if it's a man, they may do ultrasound because they don't take good mammograms with a lot of muscle tissue. You need a lot of fat tissue in your breast for a mammogram to really show up well. In an MRI, that would be only referred if there's several indications that indicate something's not quite right and they need to do something differently about it. So the provider is the one that determines which of these tests. I'm going to show you a couple pictures just to give you an idea of what the experts see. So mammograms, they may not be perfect. And when I say they're not perfect, it actually is probably about 1/4, 1 out of 4 cancers aren't visible on a mammogram. And what they do is that you have to also handle the breasts, which for some women with different racial groups, different religious beliefs, they may not want the provider touching their breasts. And you, as a navigator, you try to work with the woman and find a way that a provider can touch the breast and not be as offensive to her. And sometimes that means that she keeps her slacks on while she's having the breast examined. So palpation means that they're touching and they're trying to feel the breast tissue itself. And that's what this next picture is kind of showing, what they'll do with the pads of their finger, and that's why it's showing the pads of the finger through here. They're going to work and they're going to try to feel through their hands unusual lumpiness that maybe they're concerned seeing these white spots that are on here. Now, these could be cysts, these could be calcifications, these can be other things that are not cancer, and that's why you need somebody who's trained to read it. So for high risk women or men, MRI may also be needed. And when you prepare for your mammogram, there's a couple things that can help the woman, because it's basically women who get mammograms. You want to not use your deodorant or your perfume because a lot of them have crystals in them. They have little calciums and little crystals in some powders that we use. And it gets misinterpreted when they read the film. They think that they have some type of a crystal that they don't. Hang on. Excuse me. I disconnected that. Okay. You also want to wear a blouse or a sweater with pants or a skirt. You don't want to have to totally take, off a dress when you come in. You want to bring the phone number and the address of wherever you got your previous mammogram. And you can typically drive to and from a mammogram. You're not under any anesthesia. The radiation that you get from a mammogram typically is less than if you took a 30-minute walk on a beach. And how it's done is, I'll show you a slide on it in about, the next slide. But it's taking clear plates. They try to squeeze the breast tissue down so they can get a good view. Again, they're working on different ways to look at the breast and look at tissue in the breast that may actually be better than a mammogram. Ideally, we're going to have a better test in the near future, like within 5 years. Will it hurt? It doesn't hurt most women. It's uncomfortable, but it's not like someone screaming with it, unless they have a lot of cysts. We had a young woman one time with a lot of cysts, and the cysts are painful, and it was hurting her so much, and ended up, she just is one of these people who develops a lot of cysts, and so that's why she was experiencing problems. And how you get one done, we have several state programs that offer mammogram as long as the woman is eligible with you, if she doesn't have insurance, if she's under a certain poverty level. And that is where a lot of you will be working with the women who fit within those criteria. If you have to pay one without going through the state mandated programs, they're a few $100s. The price can range anywhere from $200 to $500, depending on where you go. And how you prepare is like some of the previous slides, that you don't put on the deodorant in case it has some of those crystals that can be misinterpreted, thinking those are crystals in the breast tissue. The mammogram itself takes about 15 minutes. For the exam, you need to take off your shirt, your blouse, and your bra. They do try to flatten down, and they'll look at 2 different views of the breast tissue. They will do 4 views if somebody has had an abnormal mammogram in the past. And they give you a nightgown or a top or something to wear into the mammography room. So you typically are not totally naked when you're there. And you have to remove it right when you do or at least have it off your shoulders when you do the test itself. And you stand in front of the mammography machine, and a trained provider will help place your breast. And some women are uncomfortable with someone else placing the breast. Occasionally, they will ask for you as a patient navigator, community health worker, promotore, to be in the room. They don't want you in the room, that you can be outside the door, because they don't want you exposed to any radiation. So that's kind of important. You don't want to be standing right next to them. So the plates press, they make the breast flat, and it's usually uncomfortable for a few seconds while the provider takes the picture, and then it helps them to get a clearer picture, and then they release the pressure of the plates. You usually only have 2 views. Now, if you've had something abnormal, they may do 4 views. They may also recommend an ultrasound if they see that your tissue is very dense, like the X-ray that you saw a few slides ago. It had some white spots in it. You'll see some mammograms with younger women in particular, or women who are very, very physically fit, that their breasts are solid black masses. And so they have to look for the cancer in a different way. Now, the rationale, supposedly from the U.S. Preventive Task Force, for women who are between the ages of 40 and 49, is that they basically show that it's not cost effective. And there's an issue with this, because with different racial groups, such as with American Indian women, half of our women are diagnosed before age 50. We cannot wait until we're 50 to start taking part in breast screening. But that is why going through programs, such as I've mentioned before, Susan G. Komen for the Cure, Avon funding, and others may help. So basically, they were trying, different radiation specialists were trying to say, look, we can actually look at doing a different types of mammograms, such as with digital mammography, and it should be pretty effective. The U.S. Preventive Task Force right now is still saying there are insufficient data to support using digital mammogram. You will have radiation therapists such as Marilyn Rubidoux, who actually found out that the digital mammogram was about 50% greater, and it was 25% less radiation that the women were exposed to. So this is a fight that's going on right now, but it means that if through your program you have access to digital mammogram, because we do have digital mammogram in several places throughout Colorado, and we have someone from California. In many places in California, they have digital mammography also. You want to make certain that the people who are going to benefit the most from it get a chance to use it. So this is where the young women really can benefit. To give you an example, this is the regular film for mammogram. Now this is the same breasts, and this is digital mammogram. Look at the difference in the detail that's on this slide. So what we see for some of this is for women who are under 50, if they have an aggressive cancer, they have a much greater chance of death, and digital mammography may be a way to actually prevent or to get them diagnosed earlier, get them into treatment in an earlier age. And when you're younger, you don't have as much fatty tissue in your breast. You have what's called dense breasts. But only half of these women who have cancers using the film mammography are being diagnosed, which is another case for the digital and some of the new cases. So we get more years of life if these women are diagnosed earlier. So it's something that you have to find out from your local area, what's available and how you get people in and what makes them eligible to be able to have access to this. We'd asked the state to give us a breakdown of different populations, and we were not able to get it. We do have a few things from the cancer plan, and I'll show those in a minute. Now, the current screening rates, this is according to the Colorado Cancer Coalition plan. For women 40 to 49, if they'd had a mammogram in the past 2 years, right now, to reach the 2020 target is they want to have 63% of these women who have had a mammogram, so they've had a baseline, they want to have them come in again. And many of them are not supported by U.S. Preventive Task Force, only if they're high risk. So we're below where we need to be so far. And women who are 50 and older who had mammograms within the past 2 years, we're closer. We have 81%, but we're still not up to the 2020 target, and that's right around the corner. So we're trying. These are the women who are covered by the U.S. Preventive Task Force, which means they can get reimbursed for their screening costs. So if you look at active screening in the United States, this began in the 1980s. Because of the active breast screening, the death rate overall has decreased by 38%. So that's an amazing drop for cancer. So when people say, oh, I don't want to be screened, there's no reason to. No, this is why we do screening. We're trying to prevent deaths. We're trying to increase quality of life. And this is all that's from the American Cancer Society. Now, you are going to hear arguments from different organizations about what type of screening to take part. So, for example, this is the American Cancer Society in this column, and they're saying, hey, you should start at age 45, and it should be the individual's choice if they want to start earlier. And when to stop, it's like life expectancy, less than 10 years. So if your life expectancy is to live to 90, then this is saying you can stop being screened at 80. Interval, they're saying 1 to 2 years. Now, U.S. Preventive Task Force is saying 2 to 3 years. They're saying it stops to 74, and they're saying it's age 50. This group is the one that sets the standards for treatment that almost everybody, any cancer center is going to be using this network recommendations. And they're saying start at age 40, have a baseline to actually see what the breast tissue is like. And they don't have an upper age limit. Part of this is because you have women who are 75, keeping in mind, if U.S. Preventive Task Force, you're not supposed to go beyond this. Well, 75, we've got people now living into 110, hundreds are not that unusual anymore. So many people are in their 90s, and they're saying, why? Am I not worth anything once I turn 75? And those are some of the comments that you get from the elders. So there is controversy. You just need to find out what your local program, what you are allowed to follow, and how you get reimbursed. You don't want to be referring people in for screening that they're not going to get reimbursed, and they're not going to get stuck with the bill. Now, these next few slides are talking about high-risk screening. So this is someone who has had breast cancer before, or they've had a different type of cancer. There's a family history of cancer, or breast cancer in particular, breast, ovarian, colon. Or they have a genetic marker. For these, what makes them a strong history is that first-degree relatives refer to your parents, your siblings, and your children. If you've got that in your family, that puts you at a higher risk. That what they want to look for is that you had your initial mammogram screening before the case was identified in the family. So let's say your sister was diagnosed with breast cancer at age 50, at age 40 to 43, that means that you can start taking part in some of the screening that's in here. The calculated breast cancer risk is about 20%. There actually is a particular formula that's used for this, which again, the provider would help you with that. When we hear of something that's like 4% higher, 5% higher, those of us who work with cancer all the time, we stop and we take note. And when somebody says that a patient has a 20% increased risk, that's big time. That's big time. You work extra hard to try to support those patients, getting them into screening, and if something's abnormal, getting them through their follow-up care. The BRCA1 or the BRCA2, if you have a mutation, that definitely puts someone at risk. There was a lot of misinformation in the early 1990s when BRCA1 was first recognized or identified, and they were saying 70% of people who had it developed breast cancer, and in particular if they had Jewish ancestry. It was Ashkenazi Jew particular, which is a very large Jewish population, but it's not 70%. Over the years, we've learned that it definitely is an increased risk, but it's closer to maybe 25%. But it's still, that's a big thing. So these people really have to be followed carefully. And they begin annual screening and MRI at age 25 or 30 years of age. And we have to be aggressive with those types of things. So if they're looking at the mutation, then they start doing annual mammograms, not every 1 to 2 or 1 to 3 years, at age 30. And then they'll do a different types of irradiation between 10 to 30 years old. The mantle radiation is something we don't like to do very often. It exposes a lot of the body to unnecessary radiation. But if you have a child who has BRCA1 or BRCA2, this is one of the recommendations. They're saying we should be screening them at this age. This is being debated by other groups who say that child who is exposed to radiation, it may actually be stimulating other types of lymphomas or other cancers in them. So this is not a solid. So take this with a carton of salt. We don't know yet a lot of it. So they're saying, others are saying, don't do it under 25 years of age. Younger breast tissue is more sensitive to radiation than older breast tissue. another reason that we don't want to just do something so blatant. And triple negative, we see excessive amounts in African American women, but it's also in other racial groups. It's just not as common. And triple negative is another very aggressive cancer. And it's another one that when we have a patient that we're working with who has triple negative, we have to work extra hard to support them to get into not just the diagnostic services, but the follow-up treatment and care. HER2/neu, same thing. There's very specific, Herceptin is the medication that seems to do the best with HER2/neu, whereas Herceptin doesn't do much for ductal carcinoma. So they have to really tailor their treatment to the type of cancer. And this is one of the fact sheets that came from a cancer screening group, and it's saying, hey, you've got a choice to start doing annual breast screening at 45 to 54, get a mammogram every year. Now, keeping in mind, that's not what's recommended by U.S. Preventive Task Force, which is what you have to follow for some of your programs. If you're older than 55, you may get it every 2 years. So you see it kind of varies. And if you're expected to live 10 or more years, that's probably when you can stop having a mammogram, because the cancer would grow so slowly in 10 years, it would not be the cause of death. So most women who are at high risk should begin screening with MRI and mammograms when they're 30 and continue as long as they're in good health. So you see there's different guidelines, different recommendations. Make certain you're comfortable with what your clinic recommends and how they're going to reimburse. Now, this next slide is going to show you a little bit of overall data for the U.S. because I couldn't get it just for Colorado. So the estimated new cases in 2018, this is how many they're recommending. And the percentage of all cancer that will be breast cancer is about 15%. Now that's important because tomorrow we're going to be talking about cervical cancer for those of you who are going into this. And cervical cancer is a much lower risk. So 15% of all new cancers in the United States are breast cancer. That's major. That's major, especially now that we can get breast cancer under control for the majority of women. So the estimated deaths in 2018 is almost 41,000 people. And that's 6.7% of all cancer deaths. The percent of surviving breast cancer now is almost 90%. So it used to be like 20 years ago when we were working with breast cancer, we didn't have figures anywhere near this optimistic, this good. So the impact, the number of new cases is we look at per 100,000 to kind of get a guesstimate. So this is saying it's just in females, about 126 women out of 100,000 women per year. And the number of deaths is about 20 or 21 per 100,000 per year. So it's about 12.5% of women are diagnosed with breast cancer and this is why we take part in screening. So we have 3 million, almost 3.5 million women living with breast cancer in the United States. That's amazing, how common this is and what we can do about it now. So the 5-year relative survival. So for the women who are diagnosed with cancer, if it's localized, it's this dark green. And look at the 62% are likely to have a good 5-year life. If it's distal, that's this one here. It means the cancer has metastasized or it has spread. And this is later stage. So we're looking at less survival. 31 means it spread to the lymph nodes, and we have trouble then with lymphedema and other conditions on that. But this is very, very important to kind of pay attention to why we take part in screening. That's why, right? That's why. These people are going to live, and they're going to live likely normal lifestyles. This figure is just showing for breast cancer, new cases, number of deaths. that out of all, that's 15% of all these. So it's 3 different ways to look at the impact of this. So breast cancer incidence, it's most common in middle-aged and older women. Men also develop breast cancer. It's much more difficult to get these men into screening or to get their screening paid for. White and Black women have excessively high incidence compared to other racial groups. White women are the highest, but the Blacks are catching up. Here's an example. Look, for all races, for the averages here, here's white women. Look how close Black women, they're almost as high as white women for this. So when we talk about disparities, we usually talk about our minority groups, but for breast cancer, the group that is affected the most is white women. But I want you to look at how these data can vary. Here's my population down here, 82.6. Looks darn good compared to 126 per 100,000, right? But look at the next slide. So on this slide, our breast cancer risks, these are non-Hispanic white. These are American Indian women. Their overall rate for the whole US is 84.7. This is a little bit older data, but it actually hasn't changed a whole lot. For Alaska, the risk is 139 as compared to 126 was on the previous slide. Northern Plains, 112. Look at down here, Southwest, 50. So the previous slide cited American Indians or Alaska Natives as 82.6 per 100,000, but you can see it varies by where the women are from. Now, for those of you who are working in the southwest corner, you will have the majority of your risk is going to be a combination of this, 115, which is close to the 126 that you had on the previous slide. And 112, you actually are closer to the Southern Plains data when we look at what's happening in the Southwest. So this is looking at new cases. Again, look at these different rates as compared to what we had on the previous slide. So this is looking at it just by region. These are non-Hispanic white. These are American Indian. So this is Northern Plains. So look, it varies that we have higher American Indian women compared with people who are non-native in the same area. So it's very, very important to kind of pay attention to some of this. I'm sorry, I said it just the opposite. The American Indian women are in the pink. So lifetime probability for developing cancer for women, for breast cancer, it's 1 in 8 women. We used to get hit with this all the time in our program because we're a very small community-based nonprofit. And people would say, well, are you worried? You're working around cancer all the time. Are you worried you're going to get it? We said, well, right now there's 8 of us, and according to the data, about 1 out of 8. So it's real likely that one of us could be in there. Now, it doesn't have to be one for every 8 or any case. As it ended up in our group, that is exactly what happened. We did have one of our Native sisters, our Navigators, diagnosed. So this just gives you an idea of how common cancer is. So for women, breast cancer is the highest probability. Lung cancer, 1 in 17. And again, we'll be talking about that next week. You'll see that cervical cancer isn't even on the list because it's not as common. So strategies that patient navigators can integrate to increase screening. So we have the Colorado Cancer Plan has different recommendations. They find that if you work with different patients and you actually have a discussion with them to talk about the advantages and disadvantages of having to take off work to go in for screening as compared to being diagnosed when it's early stage and having almost a 90% likelihood of having more than 5 years of quality life is pretty important. So to really kind of get a discussion with them and to make certain you remind people to come in for their appointments, whether it's in print or by phone. Working with underserved, underscreened women in Colorado, phone is definitely the way to go. If they do text messaging, which more and more of our people throughout the state are doing text messaging, find out if the person would prefer to have a reminder by a text message. So in here, you just also kind of, if you're doing text messaging to other people who haven't been screened, getting other survivors who will give messages about the importance of screening and how it's helped their life and how they're seeing their grandchildren graduate from school. Doing one-on-one as well as group sessions, sometimes for professionals. A lot of times we find when our navigators, or community health workers, promotores, do the education in small groups in the community, that it has a greater impact of getting people into screening. And it takes some time to get comfortable doing a group presentation for that. But we do find that people relate to the navigator member. And so it helps a great way in that. The other thing in the Colorado plan is that you want to use evidence-based practices. And I'm going to show you how to find some other information that's evidence-based. So for screening, they're saying you want to emphasize the benefits of early diagnosis and higher quality of life. And you want to support the training of navigators and others, also about the availability of insurance, but we are not insurance brokers in our fields. And this is just taken straight from the Colorado plan and saying, hey, we want to increase high quality guideline, meaning like U.S. Preventive Task Force cancer screening among specific population groups. So here it's showing, just breaking down for women 50 and older who have had a mammogram within the last 2 years. The baseline was 69% as of 2014. We're trying to get it up to 81%, and that's where you come in. If you're living in rural and frontier counties in the state, which is the large proportion of here. I live in Park County. We are rural. But a lot of you live in the Southwest. Some of you are in the Northwest. Our woman from California, you're in the middle of the state. You're not in a city. You're in a rural area. And you have to kind of figure out, how do you get people in? How do you help with transportation to get people in? And people of any racial group who live in poverty, we're trying to increase them taking part in the regular screening. We want to get 81%. And right now, as of the 2014, we are quite low on that. So we want to increase services, including colonoscopy, mammography, low-dose lung, CT scan. In rural areas, we want to use mobile services. We want to have traveling providers. We want to have increased, better equipment, such as the digital mammography and other types of aspects. We want to have better partnerships. So some of you work out in very rural communities. You feel like you're all on your own. This is a chance to really develop a better partnership with the clinic, where maybe you bring people in for the services so that you can get a better communication and say, hey, I got a woman, Mary Lou, and she's got lumps, she needs help. How can we help her? And work together as a team in there. And you have to be culturally relevant, which is, again, one of the big powers of navigators, patient navigators, community health workers, and promotores, is your community. And there are cultural nuances that are very important in here. We had a male American Indian, and a non-native was working with him and touched his braids to move him out of the way. And you're not supposed to touch a man's braids. We don't call them pigtails, by the way, either. But if you have a cultural navigator, they know things like that, and they know to be more respectful of the people, which is some of the big values of having our people, or from our own cultural groups, helping out. And the Colorado Coalition is encouraging enrollment in private insurance. I'm all for this. I'm just not in favor of navigators having to have this role. It's been a confusion from the Commission on Cancer and from some other misinformation on it, but it is important to have people get into insurance policies. And anyone who's Medicaid eligible, so let's say you have someone who's in a wheelchair, who has different types of disabilities, or they're high risk for cancer, Medicaid can jump in and help support the cancer rather than taking your limited monies from the state-supported programs. You can go through Medicaid to support both their screening and their treatment. And the other thing is that what they're suggesting through the coalition is that you try to educate providers really on insurance coverage and what can be done to improve this. And you want to educate employers on the importance. Now, in all likelihood, patient navigators, you're not going to be asked to come in and educate your employers, but occasionally it happens. So it's something that you still want to realize your other resources. Now, the community guide is a free resource that can help you find evidence-based strategies. So the website is included here. And an example, I just took out one example. It shows you what the best practice is. And it tells you stories from the field. It finds out what you missed. It gives you access to some of the educational materials, the handout materials. So if your program is funded by a federal funder in particular, you almost have to use evidence-based programs. Now, state programs prefer it also, but state programs also realize that evidence-based practices have to be modified for rural Coloradans or for mountainous regions of Colorado, for rural areas in California in particular. California has been very good about modifying interventions. So some consider evidence through research, and others consider what we have through stories or experiences. And the best evidence is probably a combination. But research has said, and what we know, it really happens in the field from real people like you who are out there. So the limitations of the community guide is that it's based on a small number of projects. The definitions can be very specific to a particular area or particular region that does not relate to what you're doing in your region. The cultural competency frequently is totally lacking in the community guide, and you have to be a little bit careful of that. It assumes you have clinical access, and many of the areas where we work throughout Colorado, we don't have great clinical access. It's quite a long distance to get in for care, and we don't have the highest quality equipment. And most of the outcomes that are summarized in the community guide are short-termed, and it assumes that you have administrative support. And in many of our programs, the administrators are very naive about what a patient navigator does, a community health worker, or a promotore. They don't quite get it. There's also issues with geography, where the evidence may have been implemented is not in a geography that's close at all to where you work in your local community. Looking at the conditions of your roads, the monsoon season, some areas where you work, your roads are completely wiped out. We also have incredibly cold weather at different parts of the year. And some parts of our state, and even a few regions in California, we're actually considered a frontier, which means it's a very, very small number of people in there. And there's limited time to actually tailor the project. There's another site that's from the National Cancer Institute. It's research-tested intervention programs. That's where our tips comes through. And it will break down a lot of these different types of programs. It will provide resources for you so you can say, hey, I want to know what types of handouts or community materials they use so that I can modify them for my community. This is an example of patient navigation. This one was in Hawaii. There was a variation that was also in another one of the Pacific Islands. But they give you a variety of different materials so that you do not feel that you are starting on your own. And I don't know what happened to my little block there. Okay. So that's a quick run through of different strategies. How about questions? And